Decades of improved pediatric survival have shifted the clinical profile of sickle cell disease. In the modern adult patient, the condition is a complex multi-organ syndrome defined by the slow, cumulative destruction of microvascular networks. While pediatric care focused on managing acute pain, the adult reality is a 20-year life expectancy gap compared to the general population. In the United States, the average life expectancy for an adult with the disease is approximately 54 years. This early mortality is the result of progressive, cumulative organ damage. By age 30, the clinical challenge moves away from episodic crises toward the management of chronic kidney dysfunction, heart failure, and pulmonary hypertension. Treating adult patients requires a shift in medical strategy. Physicians must move beyond reacting to acute pain episodes and implement aggressive surveillance to intercept systemic multi-organ failure. The entire pathology originates from a single microscopic error, the inheritance of abnormal beta-globin alleles on the HBB gene, specifically a substitution of valine for glutamic acid at position 6. To manifest clinical sickle cell disease, a patient must inherit at least one of these specific beta-S mutations. Inheriting a single allele results in the sickle cell trait, which carries specific localized risks but does not cause the systemic disease itself. This singular point mutation physically alters the behavior of hemoglobin under hypoxic conditions. When deoxygenated, the mutated hemoglobin S links together into stiff polymers, warping the red blood cell from a flexible disc into a rigid crescent. Every macroscopic clinical crisis the patient will ever face, from an ischemic stroke in the brain to avascular necrosis in the femur, traces directly back to this localized structural defect. Because different hemoglobinopathies require vastly different treatment protocols, clinicians must accurately distinguish qualitative structural defects, like sickle cell disease, from quantitative globin chain imbalances, like the thalassemias. Standard solubility tests, such as SickleDex, are clinically inadequate for this distinction. They detect the presence of hemoglobin S, but they cannot differentiate a patient with severe homozygous HBSS from a patient with the largely asymptomatic sickle cell trait. This hemoglobin electrophoresis chart shows the mandatory diagnostic standard. Here, we see the precise footprint of homozygous HBSS, a massive peak indicating 80 to 95% hemoglobin S, an elevated HbA2 peak, and exactly 0% normal hemoglobin A. Compare that to the second chart showing HbS beta-0 thalassemia. Both charts show an identical absence of HbA. The key differentiator is the added data point of a low mean corpuscular volume, indicating the microcytosis characteristic of thalassemia. Precise genotypic diagnosis dictates specific surveillance and long-term therapeutic pathways, ensuring the clinical strategy matches the specific biological risk of the patient. Once mutated hemoglobin S polymerizes, it triggers a dual pathology. The disease advances through two completely distinct parallel pathophysiologic streams. Stream 1 is defined by mechanical vaso-occlusion. Deoxygenated red blood cells polymerize, lose their flexibility, and physically jam the vascular network. This mechanical jamming starves surrounding tissues of oxygen. It causes localized acute ischemic events that typically present as severe bone pain crises and, over time, permanent joint destruction through avascular necrosis. The highest stakes consequence of this vaso-occlusive stream occurs in the lungs, presenting as acute chest syndrome. Acute chest syndrome is defined by strict diagnostic criteria: a new pulmonary infiltrate on an X-ray, combined with at least two respiratory symptoms: pleuritic chest pain, hypoxemia, tachypnea, or fever. Managing this mechanical blockage requires immediate, targeted intervention. Clinicians deploy broad-spectrum antibiotics to cover atypical pathogens and manage pain aggressively, while specifically avoiding routine IV fluids unless clinically necessary. Stream 1 relies entirely on direct physical obstruction of the vessels, creating localized ischemic emergencies that require rapid, protocol-driven clinical responses. Operating alongside mechanical blockage is Stream 2, intravascular hemolysis. This is a parallel process driven by the sheer physical fragility of the sickled red blood cells. As sickled cells burst in the bloodstream, they release cell-free hemoglobin into the blood plasma. Outside the safety of the red blood cell envelope, this cell-free hemoglobin acts as a highly reactive, destructive molecule. This cell-free hemoglobin acts as a potent scavenger, rapidly binding to and depleting localized nitric oxide. Without nitric oxide to keep the vessels relaxed, the endothelial walls undergo profound vasoconstriction, thickening and triggering chronic inflammation. This constant biochemical inflammation drives an entirely different class of complications from Stream 1. It destroys the integrity of the blood vessels themselves, leading directly to strokes, priapism, and severe leg ulcers. In the cardiopulmonary system, this endothelial dysfunction manifests as pulmonary hypertension. Diagnosed via an elevated tricuspid regurgitation velocity, it is a lethal complication with a stark 37% 6-year mortality rate. In the kidneys, this same vascular destruction drives sickle nephropathy. It begins subtly as an inability to concentrate urine, known as hypostenuria, and steadily progresses through hyperfiltration into albuminuria and end-stage renal disease. While Stream 1 is defined by localized mechanical roadblocks, Stream 2 is a relentless biochemical cascade. It permanently alters vascular tone throughout the entire body, driving the chronic organ failures that define adult mortality. To combat these cascades, blood transfusion is a logical intervention. But in hemoglobinopathies, introducing donor blood carries severe risks and must be deployed with extreme precision. Simple transfusions are indicated only for highly specific events: symptomatic acute anemia, acute splenic sequestration, or parvovirus-induced aplastic crisis. They are not used for routine vaso-occlusive pain. Look at these two parallel meters. When a patient suffers an acute stroke or severe acute chest syndrome, clinicians must escalate to an automated exchange transfusion. This process actively removes the defective cells, dropping the total hemoglobin S fraction below the critical 30% threshold. Repeated transfusions introduce the severe risk of alloimmunization due to antigenic disparities between donor pools and recipients. To prevent the patient's immune system from rejecting the blood, protocols mandate extended antigen matching, specifically for Rh and Kel variants at a minimum. The ultimate danger in this process is hyperhemolysis syndrome. Here, a delayed transfusion reaction spirals out of control, triggering an aggressive immune response that destroys the new donor blood cells alongside the patient's own endogenous red blood cells. In hyperhemolysis, the very act of giving blood becomes lethal. It dictates an immediate cessation of all transfusions and a rapid pivot to immunosuppressive therapies like IVIG and corticosteroids to halt the destruction. Because managing complications downstream is highly dangerous and chronically taxing, modern hematology focuses on targeting the molecular trigger directly to halt the cascade before it begins. Hydroxyurea stands as the established first-line pharmacotherapy for adults suffering from 3 or more severe vaso-occlusive crises in a year. This timeline illustrates how hydroxyurea physically interferes with the disease process. It induces the production of fetal hemoglobin, or HbF. Because HbF cannot polymerize, its presence directly interrupts the chain-linking behavior of mutated hemoglobin S, preventing the red cell from sickling. Despite its proven ability to reduce acute pain episodes by 44% and decrease overall mortality, a massive clinical implementation gap exists. Currently, only about 23% of eligible adults actually receive the drug. We possess effective pharmacotherapy to suppress the disease, but its widespread underutilization guarantees that the biochemical cascades of Stream 1 and 2 continue unchecked in the vast majority of the adult patient population. The ultimate clinical goal is to move past disease modification and completely override the genetic defect at the stem cell level. Allogeneic hemopoietic stem cell transplant provides a proven cure. However, it is severely limited by biology. Only 14 to 20% of patients possess a fully matched sibling donor, leaving the rest vulnerable to severe graft versus host disease. The clinical landscape reached a turning point in late 2023 with the FDA approval of gene therapies, specifically the gene editing approach known as exa-cel. Exa-cel operates through precise genetic editing. It utilizes CRISPR-Cas9 to locate and cut a specific erythral enhancer called BCL11A. Disabling this enhancer removes the biological brakes, prompting a massive reactivation of fetal hemoglobin production. By flooding the system with protective fetal hemoglobin, the therapy overrides the behavioral effects of the beta S mutation. In clinical trials, this specific genetic edit completely resolved severe vaso-occlusive events in over 90% of treated patients. The process, however, demands intense clinical preparation. Before the edited cells can be reintroduced, the patient must undergo myeloablative conditioning with chemotherapy drugs like busulfan to clear space in the bone marrow. By successfully manipulating genetic expression, modern hematology can now permanently sever the link between a single point mutation and the deadly dual-stream pathology of adulthood.